Perfect. Okay. Welcome, everyone. Thank you for joining us today for our June Health AI Hub. Our Health AI Hub collaboratory rounds bring together experts and practitioners to share and explore various aspects of the AI lifecycle management in healthcare. And these monthly gatherings are designed to keep you informed about the latest trends, best practices, and challenges in this continuously evolving field. So thank you for joining us. Um, as a heads up, we'll have next month's speakers are from Manat, and they will be presenting on their Health AI policy tracker. We're looking forward to welcoming Jared Augenstein, Annie Fox, and Randy Seigel. So go ahead and register for that today. And we'll see you at the end of next month as well. And we also have a real world AI series coming up in July on artificial intelligence guided screenings for cardiomyopathies in an obstetric population. And so Dr. Adenwosu will be sharing results from her RCT. So we're looking forward to that in the next couple of weeks as well. And then without further ado, I will turn it over to Hang from Define Venture Capital, who will be presenting today on findings from inside the C-suite, so payer and provider leaders and their visions for the future of AI. We're super excited to have Hang with us here today. So thank you.
Thank you, Sierra. Nice to be here and excited for the conversation today. Feel free to keep it conversational and jump in whenever you feel the inkling. So I love conversation here. And also love seeing some familiar faces. So hi, Matt. Um, so just quickly on me, and thank you, Olivia and Sierra for having me. I'm an investor here at Define Ventures. My entire career has really been at the intersection of the traditional healthcare ecosystem and this world of venture capital and startups and entrepreneurship. So I had started my career in pharmacoeconomic consulting, so really working with life science companies. But for the majority of it, have really worked with large healthcare organizations, including Kaiser Permanente, Cedars-Sinai, Memorial Care, and then more recently, the California Healthcare Foundation, which was focused on the safety net. And so have a broad view across technology, innovation, and then specifically data as well across these sectors. And I joined Define a couple of years ago. And here at Define, we're more of a traditional institutional venture fund. We were born um, out of Kleiner Perkins about 7 years ago, and we are now about 800 million under management. So really grown at a very healthy clip of two funds, a new flagship fund every 2 years. And we have also grown our partners. So we're up to about 30 partners that we have to date. We're here in San Francisco, so very close to the valley, as you can imagine, with our origins from Kleiner Perkins, and we're early stage investors. So that means we work with companies from inception of concept at the seed and pre-seed levels, all the way to Series B, at which they have more product market fit. And we have an incredible team. And the way to think about us in the world is that, we are a distinctive venture fund in that we truly sit at the intersection of healthcare and this world of tech. And a lot of it really comes back to the team and the ecosystem of people, advisors, and partners that we bring to the table. So you sort of heard it from my background in terms of the depth. I'm a career healthcare person, and again, at this intersection of innovation, data, and healthcare. And we just have a phenomenal team and really stacking the bench here to bring expertise to our partners, to our entrepreneurs, to our strategic partners as well. In the last year, we've grown a step function in terms of bringing on some incredible depth to our team. And maybe some of these names will be familiar to you, but Frank Williams has joined us as a venture partner. He's formerly one of the founders of Evolent, so certainly knows the health system provider world and value-based care incredibly well. From the payer perspective, we have Bruce Broussard, the former CEO of Humana, so certainly a household name, at least in our industry, and Carolyn McGill, who was CEO of Aetion, worked with life science companies, but also had worked with Frank in the early days of Evolent and then managed multiple markets for United as well. So you can think of us as the depth we bring to the table of industry knowledge and networks. But again, just coming back to our roots here in Silicon Valley and being born from Kleiner Perkins, the set of advisors we bring to the table is really cross-industry. So on the one hand, we have people like Peter Fine, who joined us recently, who's formerly CEO of Banner, Toby Cosgrove. We also have great Silicon Valley leaders who we work with closely to give our companies, our partners, strategic partners, a different perspective as to, how technology can be impacting healthcare. So Jolly over here is a professor at Stanford and one of the early people who founded Google Cloud AI. Ashley Yuki, who is head of product at Instagram, and Bengali with his experience at Instacart. So really, we sit here truly at the intersection of Silicon Valley, tech, and healthcare, and we mind melt these two industries together in the way that we think about the world. So when ChatGPT became a consumer phenomenon a couple of years ago, we really set out to understand how were our partners, our strategic partners, thinking about this, and where in the world were they as in terms of acceptance. What we realized was that many of our partners honestly were a bit overwhelmed. You know, one, it was just the question of what is this? How can it be used? But two, what became increasingly clear is that the pace of technology and the evolution of it was just so fast. And that everyone was catching up between trying to understand how do you implement this within their systems and at the same time trying to keep up with what's also coming out next. And we know these are moving at very different paces between implementation and technology here. And so we set out to do a couple of things with our partners. One, because we set out to create truly an ecosystem and a community of our partners, really bringing together, again, our expertise and our networks in Silicon Valley, along with some of our strategic partners. So about a month ago, we hosted an AI summit with Warner Thomas, the CEO of Sutter, alongside John Doerr from Kleiner Perkins, and brought in, C-suite leaders like the chief data officers of Common Spirit, of Cleveland Clinic, of Stanford, to meet with Greg Brockman, one of the founders of OpenAI, and Brett Taylor, the exec chair of OpenAI. So that's the ecosystem that we intend to bring together. Silicon Valley tech, what's happening out there at those front lines of development, our entrepreneurial communities who are really building solutions with these tools out there, and then our strategic partners too. And we welcome you all to be part of that conversation as well. The other thing we aimed to do was to bring some data to the table. Everyone at that point was really informally gathering, having conversations with themselves, and we just wanted to, amongst our community of partners, help them understand where their peers were and have the conversation as to what some of these learnings were. And so that's what we set out to do. We did a survey of six, and we approached 63 of our closest payer and provider partners here, and really wanted to help understand from them where they were in the implementation journey, what they were evaluating, what they were interested in. And the interest was overwhelming. We got of the 63, about two-thirds of whom were actually at the C-suite level. So we were really getting a high-level strategic perspective as to where they were, what they were thinking about when it came to their AI strategy. And it was a really great mix between payer and the provider side. On the payer side, about a quarter were represented by national payers, and then, of course, a lot of regional and state players as well. On the provider side, we were a bit more health system focused, and certainly a lot of AMCs and more regional providers that participated as well. But very high level C-suite leaders, and of course, our network tends to be leans a little more towards some of the more forward-thinking organizations in this space. So in my entire career, having worked at Kaiser, Cedars-Sinai, Memorial Care, and even the California Healthcare Foundation, there's certainly been many themes that have come up between telemedicine, interoperability, and among others. I would say AI is really taken the cake in terms of the amount of interest that's there. In our survey, over half of our participants had said that this was an immediate or urgent priority, truly top priority for our organizations. When you include those who also thought it was somewhat of a priority, we're talking about nearly everyone. Is over 90% of participants said yeah, they were thinking about this at this point. About 22% their budgets were actually increasing. Another half said they're increasing somewhat. And then what we thought was most interesting as we started to think about how do you segment who was adopting AI and what their approaches were, as we took a closer look at the governance committee, organizations started to separate themselves out in some ways. I would say there have been many learnings for organizations. 73% have established something of a governance committee, another 22 were moving in that direction. Needless to say, it was very hard to adopt AI without a governance committee, and some organizations learned it the hard way. And then, not surprisingly, AMC's had some version of an AI committee established for a long time just because of the research nature of the work that their organizations did. But the buckets that organizations really fell into were three. At a very minimum, the AI governance committee was intended to do the basics, which was anytime someone wanted to do something that included AI, that this committee would review it and ensure that there was safety, ethics, all the data policies were being followed. I would say that was ground stakes. What and then beyond that, organizations really started to separate themselves as to, is this about protecting ourselves and protecting ourselves against the liability that comes with the uncertainty of generative AI? Or are we an organization really spending money here, leaning in? Those that were leaning in added additional functionalities that were less, ways to say no and more, how do we get to yes? They included additional functionality like, active, proactive evaluation of vendors and solutions. And we all know this, but interdepartmental collaboration between IT, finance, business line leaders, and then the very proactive ones thought very hard about how do you actually start to identify budget in order to fund some of these initiatives to begin with. And as we thought about, how providers and payers differed in this space, I think the findings were reasonably stark. Maybe not surprisingly, and just because provider organizations are obviously very service heavy, the providers were really much further into adopting AI solutions than payer were. 31% of providers said that they were going to increase their budgets pretty significantly, and then another 38% said they would increase it somewhat. And then among payer organizations, only about 6% were increasing it significantly, and then 75% increasing them somewhat. I was really among multiple different angles in which they are different. I mean, there's some hypotheses as to why this is, and I'm curious for the audience members how they think about this too. Among payers, there's certainly been publicly a lot of scrutiny as to how payers are using AI in their own practices and what's fair or not. And so I think there's been a lot more sort of trepidation when it comes to payers and adopting AI more broadly. The use cases were quite significantly different as well. On the provider side, not surprisingly, clinical documentation, I think just the widespread availability of scribes is becoming a lot more common and table stakes for many organizations now between, trying to attract and maintain clinicians. And actually organizations using it as a tool to win over clinicians. And beyond that, the low-hanging fruit have been much more administrative use cases between, RCM, there's some sort of identifying of disease for, improving access, and increasingly patient communication, while generally all sort of sitting in the more administrative scheduling perspective. On the payer side, as far as payers do lean a little bit more clinical, that's often where they spend a lot more time in terms of their AI, or at least where they really want to be investing more. First and foremost is communication and engagement. I think providers generally have as they are often not the providers of care themselves, really struggle with this and have been thinking about generative AI as a new front door, a new way to engage by making information easier and accessible. And then to the extent again that they have more clinical functions in their on their teams between nursing teams that do case management, care management, utilization management, prior authorization reviews, those are the teams that are where they're also thinking very hard about how do they use generative AI in order to gain more efficiencies. Maybe I'll just pause here, but I'm just wondering if there are any questions or thoughts from the audience so far.
Please feel free to post your questions in chat or unmute yourself and ask if you have any questions for home so far.
All right. Well, I'll keep going then. So we here at Define have been thinking about what does it mean to be ready for adopting generative AI. And we thought about it very much from the perspective, the technology stack. I saw on LinkedIn at one point someone made a comment about, I was at a conference and there was a event for data management, and then there was another sort of next door an event for AI, and the AI room was filled and nobody was in data management. And he's like, well, news to you, so much of AI is data management. And we believe that's fundamentally true. Without the liquidity of data, the preparedness of data, you're not going to be able to access and really tap into the full capability of AI. And so this is how we've thought about all those different layers that an organization might have or need to have in order to be truly AI ready and enabled. These will not be unfamiliar to you at the very bottom and basis. You just need the compute power, and cloud compute especially, as opposed to on-prem, although we know there's straddling of the worlds. Of course, the foundation models. We'll talk about this a little bit in the next session, but for the most part, the off-the-shelf models work reasonably well. And then in some rare cases, organizations are actually building their own model for very bespoke purposes. Um, and then all this sort of data munging that goes in between the ETL data pipelines. This is where Snowflake and Databricks have really taken the market, all the way up to much more specific. How do I get my models to work? How do I prompt better? How do I get my agents to work together? And of course, observability, just really making sure. And this is, of course, a function that many of the governance committees are taking on as well, which is how do we think through security and compliance? How do we have observability and monitoring over time? How do we evaluate all these different functionalities as well? So we think about this as, um, whether you're an organization that wants to build, and if you are one of those, having this full stack of the full capabilities to get to how do I now use this to generate a medical appeals letter? How do I how do I, use AI to fill out prior authorizations? It's the full stack. On the other hand, there are organizations that would do all this on behalf of an organization for specific use cases. The names here that I put up are, of course, a bridge, an organization we can't stop hearing about in the news nowadays. And then also Cohere, which is actually one of our partners doing prior authorization in the health plan for health plans, and who also recently raised a 90 million Series C. So really doing well out there as well. But they offer these bespoke applications, and they own and manage this full stack on their own in order to offer these capabilities. So again, thinking about organizational readiness from the perspective of the technology stack, I think we were pretty surprised by what we found. When we first went into this journey, we really thought, hey, it's a lot for a healthcare organization to transform their data stack to really build with AI on their own. Data stacks and that type of transformation extraordinarily costly. And it takes specific knowledge too as to how do you want to manage that ecosystem? How do you, bring the right tools into place? How do you do the right prompt management? We were very pleasantly surprised, and again, with the pace of how quickly AI moves, maybe not surprisingly, a lot of organizations are thinking about how do they do this themselves. I think we were expecting a lot more organizations that were willing to sort of outsource a lot of the full stack applications and just like, hey, I need a prior auth solution and I need a vendor to do this for me. What we found instead was about, 45 and 39% that were really investing and building themselves the deployment layers and the data lake layers in order to, over time, be able to build some of those applications themselves. Not surprisingly, the foundation models on the compute are not things many organizations take on themselves directly and will outsource. But the feeling is that, in order to build applications on top of it, you need to have your data ready, and that's where there's been a lot of time and investment to date. What we also see is, and this differs a bit from payers to providers, but a lot of outsourcing for applications today. And we truly wonder whether this is a today because, not every organization is Databricks ready and data ready in order to get their full stack moving and implementing themselves. And so they're looking to external innovators and at what point it might tip where some of the low-hanging fruit between, being able to just generate a medical appeals letter or just filling out prior authorization forms, that these are functionality that organizations themselves now have the capability to do at much lower cost than outsourcing this to a vendor who might want to manage it entirely on their behalf. Um, and I think what we're seeing here is reflected in the priorities. So certainly where both providers and payers are today is really like, let's get going. Let's go try it. We're not sure what the right use cases are, and let's just get some pilots going in the next year. Again, what was reflected before about their interest and willingness to build here is reflected in this last category, and much higher than what we would have expected, which is about 50% across payer and provider organizations are building their AI capabilities in-house. So really setting out the foundation, in some cases hiring the right talent, and again, with the sort of how quickly the technology is advancing between vibe coding and the like, that sort of bar for how technical someone needs to be to implement some of these tools is getting lower and lower and becoming a lot more accessible to organizations as they think about some of these use cases. Um, I think one of the questions was about what some of the biggest challenges were around adopting AI. I would say it's really about, certainly on the provider side, about ROI. Um, I think historically, and the conversation changes a little bit with generative AI, or at least expectation does, is that technology, data layers, data infrastructure tends to be a cost center for organizations as opposed to something that's revenue generating. I think the expectation is that with the advent of generative AI, there's a lot of pockets where there could be cost savings from, either reducing, like improving access to treatment or other services, or it is about reducing costs in some capacity. I think the expectations there, hence the incredible enthusiasm, I would still say that in the early days, these are not obvious yet because of just where the industry is in adoption. So the first question every provider organization is really asking themselves before they implement something is around ROI. Is this the one that I'm going to get a return on? What we thought was interesting as we talked to some of our partners here too, much in the same way that we as a venture fund think about portfolio management. We have some investments in our portfolio that are more mature, therefore less risky. We have some investments that are much earlier, therefore more risky. Many of them are thinking about the same way as to how they balance the ROI of their AI portfolio. Going between things like scribing is pretty clear in terms of, people like this. The actual dollar ROI is a little different from organization to organization. But that we know, people will be happy about. all the way to things that are a little bit more newer and sort of to be proven, but with high expectations. Things like using AI to call patients for better adherence to, clinical protocols, or using AI, voice AI to manage call center volumes, and converting patients into new appointments. Again, lots of promise, makes a lot of sense. We're just in the early days of implementation and understanding what that looks like. And some of the organizations that we've talked to who actually have done things that sound that should be very low-hanging fruit and obvious, like implementing AI for call centers, have seen in the first couple of however long of the implementation that costs actually increase. Again, this is all just about, you know, lots of hope and expectations for what AI can do, but the implementation, and you're sort of seeing here the workflow integration, and the like, really, as it always does in healthcare, wag itself in the head in terms of how do you justify the investments that you might want to make here. Um, what I thought was also very interesting is that for all the conversations that we have around trust and safety in healthcare, if you look at the very bottom of the charts, in terms of the challenges in value AI vendors, error and bias, traceability, and auditability really fell all the way at the bottom. Um, we have a couple of hypotheses for why that might be. In part, I think it is, we're going back to the use cases here. Most of where organizations are leaning in today are in areas that they see as much lower risk. With scribing, you have a clinician who ultimately is reviewing information, financial management, RCM, things like that. It's about efficiency, and it's a lot less about accuracy. So I think while there's hope that we can move more into clinical decision support and the like, I think the capabilities are not quite there yet, or the expectations are not there yet in terms of, I think one, fundamentally the ability to even manage and understand it for each of the organizations. And I know many companies are starting to do that. Um, and then two, the need for it, just because there's still a lot of low-hanging administrative fruit to pick in terms of where AI can be applicable today. It's interesting to see the contrast with payers. ROI is also up there, sort of number two in terms of the challenges, and then number three in terms of what they're looking for when evaluating vendors. I think payers tend to be, because they are so data driven between the tech stacks that they need to manage for claims management and the like, tend to be a lot more doers than buyers of AI and technology. And so the integration challenges for them tend to be more around their team and their capacity. And again, pairs being sort of risk organizations, really thinking about data security, compliance, data access, and ownership as well as sort of the first layer of, thought, before they start to even consider, like, is this something we want to walk down? Again, with payers, especially what's happening in the news, with their use of AI around denials or utilization management, I think they're feeling particularly cautious about when and how they use AI and how that's going to be perceived in the ecosystem. Um, so where are we? This was a survey we did at the end of last year. Results were reflective of the end of last year. Again, things are moving incredibly quickly, but I would say overall, early to evidence seems pretty positive. I think, again, scribing is the most obvious one. We hear just incredible things between provider satisfaction, time back, how institutions use this, even though honestly, the ROI on it is not entirely clear today, but the anecdotal evidence has been enough where organizations continue to invest in it. And then there's just still a lot of noise, 30% net neutral, and then a good chunk of organizations have yet to really get there in terms of seeing enough, having enough time with any of these solutions to see what the benefits are. Um, and then just the reasons why things don't work out when working with vendors. I think there's a lot of promise with AI, and the first category there being about vendors over promising and under delivering. Again, a lot of promise, there's still a lot of kinks, as we all know, to work out between workflow and integration issues, change management, sort of, 2 and 3 before we can really even achieve the promise that generative AI can offer us. So I would say we as an industry are very much in a work in progress of trying to figure out how do we get to the elusive goal of being a much more AI-enabled ecosystem. Um, so that's the bulk of my presentation. And I just want to say, we as a venture fund have been very active in this space. And we love to back just incredible AI leaders here. So just a couple of investments that we've made to date to share with you all and these have been across our journey. Cohere was a company we incubated with Humana about 4 years ago, and that's been doing very well and using AI to do more utilization management on behalf of plans. We more recently invested in a couple of companies, Layer Health, which is AI for clinical chart abstraction, starting with clinical registries, which is founded by David Sontag, who is one of the preeminent professors of clinical AI and a professor at MIT as well. Solara Health, which is using AI to help improve care outside of the health facility walls. So think of this as the companion that a patient can take with them after a surgery or, if they're experiencing comorbid behavioral health challenges. And that was founded by Randy and Gio, who had also been COO and CEO of Castlight Health. And then Lumini a little more in the administrative space, using RPA plus large language models in order to automate the complexities of sort of all the documents that come in, the fax machine sort of documentation that then need to be implemented and abstracted and entered into our systems, really just taking off the low-hanging fruit of the administrative needs that organizations have to date. And so that's the bulk of the presentation. Certainly lots of learnings that we've had here, but welcome conversations and questions. I'll also just make a plug, and I'm seeing now that there's some questions in here, so I will get to those in just a second. But just a plug for all of you, certainly reach out to me if there's anything that I've talked about today that you'd like to learn more about. We will be doing a second version of this. We'd like to do this somewhat annually or every 18 months or so because, again, this industry is moving so quickly and we love to have a pulse of where everyone is. And so, again, welcome your participation, welcome your interest. And to the extent you're also interested in some of the events that we put on, please reach out and we'll make sure that you're added to the list and informed when some of these things are happening. All right, and I'm
Thank
seeing
you.
some questions. Yeah.
No, thank you so much. This was great presentation, and thank you for sharing the report as well. Yeah, I was just going to point there are some questions in the chat. I think Chris asks about do payers or providers approach the regulatory challenges equally? How are they each navigating regulatory and regulations and oversight?
Yeah, it's a good question. In my experience, I would say, when I talked about this bifurcation of organizations and how they structure their governance committees, and then as you can probably see from how some of the top things that payers are looking at, payers are much further behind, or I guess more apprehensive than providers are about the opportunity for AI and what it means for them. You know, your peers are really particularly worried about not being in the news for being a bad actor. And they are also very worried about, what it means for them at the end of the day. And they also, unlike provider organizations, tend to be a lot less services heavy. And that's where a lot of the value of AI really comes from, which is, I think the leap that generative AI gave us is that it can mimic humans. It can mimic human activity at the end of the day. And so again, the buckets where they think it's interesting or helpful is of course, administrative, but to support places where they have more significant services functions, which include, again, case management, nurses who do utilization management reviews and things like that. So they're using around the edges in the same way I think providers are hoping it'll add value, which is around reducing some of the burden and cost of managing some of these services. Um, versus providers who I think are a lot more optimistic about it. So, I think the governance committees tend to really focus in that direction as well, where, fewer of the payers are forward leaning than the providers are in our experience. And then the payers, of course, are looking a lot more towards, a lot of the federal and state policies that really impact them directly. And as we know, there's just been very active conversations at state levels between providers with the states and payers about the appropriate use of AI when it comes to some hot topics like denying care. Um, so that's been probably the starkest difference between payers and providers as to how they think about governance. Providers, I think, are still early. Again, I think there's still a lot of use cases today that don't require a lot of regulatory oversight quite yet. Things around RCM, they're purely administrative. The bar is a lot lower for accuracy. As long as they're seeing improvements, that's a gain. The conversations around what Chai is doing, the model cards, local validation of models. I think those become a lot more relevant if and when AI starts to move into much more of a clinical realm. And then Amol, you had a couple questions. You want to come off mute and ask some questions?
I'm pretty shy. I mean, so thanks for the great presentation. I've seen your documents, so you added a lot more color to it during the presentation. So thank you for that. I mean, some of them you've answered, like one was sort of around ROI, full disclosure from Canada, in Toronto, looking at a lot of the academic health sciences centers. And I think there's a huge gap still on the economic side. We obviously have a different economic system than you do, but just if you look at the cost curve of AI and then you look at sort of the pricing, there seems to be sort of a gap in terms of subsidies. A lot of VCs are funding it, which is fine. I get it. I just don't see when and how that gap will be closed. And if you look at the budgets, minus 3.6% operating margin in the US, we're probably closer to 7 to 10. Where does those sort of pools of capital come to sort of fund this stuff? My big bugaboo is it's great to have academic health sciences centers, and I'm an academic clinical physician doing all this stuff as research, but it needs to kind of move out of those walls. And I don't know how that happens because obviously look at the IT budgets of academic centers are quite different from community and regional centers, which are much smaller. So I'm just wondering, with patients getting care outside for the bulk of their stuff that they need, I'm just sort of curious, any thoughts about how, like, it's just, we wait and see, we hope sort of the cost curve continues to decline, time will figure this out and everyone will be good? Or is there something sort of proactive that needs to be done? Sorry, that was just a data dump, and I apologize for that.
Yeah, no, it's a very good question. Again, going back to, what are they talking about when and how they evaluate any sort of use case? I mean, the way that we see the world, there's like I think there's a huge promise around reducing costs. I'll be honest and say I think it's a very hard one to prove. Even things like using AI to, supplement call centers. I mean, one hope is that you just don't need to grow your call center or whatever services you're using. Um, Another way to think about it is if you had someone or AI to pick up every call as opposed to people leaving your system or not because they're unable to get through to scheduling, what does that mean in terms of the uplift in revenue you can get from people by actually capturing people at the right time and place in the way that you were never able to staff somebody to pick up every single phone call that goes through your systems, for example? So I think there are ways to think about revenue generation. I think the most obvious use cases that we've seen today is anything with coding and like appropriate capture of coding to increase the sort of payment for each of those. I think disease screening was another one that I'd mentioned. This is very much how do I look through my patient base and for patients who are appropriate for, procedures for treatment that is guideline concordant that I might have missed because it was very hard for me to go clinically abstract that information to know whether they were eligible or not. like how do I, surface those patients to my system? There's also, I talked about coding, and then even with the call center one, as I just mentioned earlier, how do I make sure that people aren't leaving my system inappropriately because I'm not able to answer everything? So these are a couple of the sort of most common use cases we hear. I mean, I would say prior auth is another one, right? Especially when it comes to specialty pharmacy. Like if I'm making money off of my specialty pharmacy, I want to make sure that it's so absolutely frictionless that a patient is getting the care that they need to, and they're not waiting or leaving our system or just like falling off the map because we couldn't get that approval from the plan, or that we weren't able to reach the patient, or we didn't follow up with them to ask them about their refills at the end of the day and make sure they come in and get that done. So I think there's ways to think about this as revenue accretive, and of course we're in the early days. But I agree with you. Again, it comes back to like, is there any capital outlay to start to pay for these things? And with, the impending sort of crunch we're expecting for a provider organization because of Medicaid, because of site neutrality, I think some systems are even thinking very creatively about how they contract with some of these organizations to just say, hey, can we do this on a risk basis? And like split the difference in terms of what we think the uplift could be. So we're entering a new world here of accountability when it comes to AI. And I would also say the other thing, um, the cost of these models is truly coming down. And we're seeing that already in the last couple of years. It's something Greg Brockman was talking about at our AI summit as well. And we've seen it with our companies who are AI forward, who tend to operate at like a 50% margin or so with AI, but really starting to see that gap widen as these models become a lot more efficient over time as well. And I think with also good engineering and creating more scalability and understanding when and how to use the large models versus small models, you can get some of that differential. But again, it's early days, but you're absolutely right. It's still a tricky question. We're all in this world of figuring that out today.
That was awesome. Can I ask just a quick follow-up question?
Ah.
I'm just curious, Han, when you did the focus group, and I know this is a taboo subject, so I'll just say that out loud first. Did any of the sort of C-suite, is there an expectation over the long term, once safety and efficacy is sorted out, that this will eat into labor cost if possible, which is the largest component of organizations? Because I know, and this is industry, like cross industry, not just healthcare, but I'm wondering, and we're not there yet, and I fully understand that, but sort of human in the loop, is there sort of a hope amongst the admin suite that, you know what, if this does work out, we will actually get uplift by decreasing labor, whether it's in the call center admin or even for some, clinical at the front desk. Like, I'm just sort of curious, was that even a discussion or that is not even in expectation? Thank you.
I would say that's the discussion. Again, all these use cases between payer and providers all around like, where they have bulks of people and services that they think they might be able to offload their books, and far less on sort of, efficiency of the systems and things like that. Again, I think it's, you know, um, the the lowest hanging fruit to date has really been what we call the swivel chair jobs. These are the people in the call centers. These are, employees that are hard to maintain. There's a lot of churn. It's low paying. The quality can be very varied if you don't train everyone properly. And so using AI to sort of standardize that and create some efficiencies there, I think, how systems decide to staff over time with the advent of AI is a very touchy subject, as you know, because this really gets to the heart of employment. I would say we're probably still too early to see what that actual impact on labor is going to be to date. But I think that's the hope over time, where step one is, hey, maybe we just don't need to hire as many people as we scale and grow. And we know that the need for services will increase over time. And in the long run, if we're really seeing a really drop in lack of need for services, maybe this is where we need to go. I think some of the low-hanging fruit, frankly, is services in which they outsource. So to the extent they outsource their call centers, to the extent they outsource revenue cycle management, these are things where, and to the extent that they outsource the management of their clinical registries, and that's what Layer does, which is, can we bring this in-house and reduce the cost of outsourcing, But, instead of having 20 nurses do this, with AI, we can have 2 nurses do this. And we can maintain the quality to our expectations and make the data a lot more useful to us. So there's different ways in which we can think about how this AI impacts labor costs and different ways as to, I think how systems can manage that kind of spend over time without some of the having to answer yet the hard questions of, you workforce size.
Uh, can I ask a very quick follow-up on the same thread? Hong, were there any discussions around like trying to understand patient satisfaction with these tools and the AI now in the loop, or maybe the AI being the primary source of like scheduling or any of those within the focus groups? I'm curious about like that aspect of like service to the patient. How are people thinking about that?
Yeah, I would say, sorry, I'm trying to get this to move in the right direction and it's not doing that. Is it going? There we go. I just wanted to go to the use cases. I would say that there's a lot of hope for the patient conversation ones. I would still say everyone's walking into it pretty carefully as to what AI, how patients are going to interact with AI. Because I think there's still uncertainty, lack of understanding, even though there's been a lot of progress around models and hallucinations and things like that. So, I think at the very least, the call center piece is entirely around just if someone calls, somebody should answer. And hey, I'm all for that. And at a minimum, what it would do in this scenarios where we've seen, it's like, let me answer the administrative questions for you, like what our hours are, collect your insurance information, ask you why you're calling in and who you want to see and route you so that a person doesn't need to do all of that. Um, and then I don't see AI yet, although many organizations are trying to get there. I haven't seen it implemented at scale where AI is doing anything remotely clinical. There is the like close to clinical, like, a patient calls an orthopedic practice and you have to ask some clinical questions about which shoulder is it? What are you experiencing? Is it sharp pain or dull pain? And therefore, maybe you want to see this clinician. We've seen it as, your colonoscopy appointment reminder. Did you follow the fasting schedule the last day? Do you have a ride coming in? That's really as clinical as most of these get today. I know there are companies like Hippocratic who want to be the AI nurse. Even then, I would say they're not doing anything prescriptive, truly clinical in its functionality. It's just asking clinical questions in the right language at the end of the day. Um, so I think we're still early. I would say there's, you know, I think the preference still is, as you're seeing on the provider side, clinical documentation, which means there's someone, a clinician looking at all this. Financial management is purely administrative. Disease screening is also purely, clinician facing or administratively facing before we're really getting down to, how do we use this to actually talk to patients?
Sierra, go ahead.
Yeah, I just have a quick question. If you go back to the slide on like key AI integration challenges for providers, um, yeah, that one. I thought it was really interesting to see that like errors and bias came in at the bottom as well as traceability and audibility. And I know you mentioned that you thought maybe some of that was because, the more administrative use cases like AI scribes are still the most common. Do you think that as CDS tools and disease screening tools become more prevalent, that will change? And if so, what do you think will become kind of the bigger challenges and concerns?
Yeah, I feel like I mean CDS has existed in a non-generative AI capacity for a very long time. I think some things around CDS are not highly contentious. Again, even things like sepsis. I mean, there's still a lot around figuring out what like accuracy is and things like that, and how it's fit for your particular organization. But I think for some CDS, it's available. I mean, and has been available, though not widely scaled. I think the opportunity for CDS is sort of what, like I always think about what is that step function that generative AI has given us, that predictive AI, and just to be a little black and white as the types of AI that exist, hadn't given us before, the predictive AI being sort of like machine learning, some of deep learning, but not quite generative AI. And it's that, you can take a insight and you can act on it. And I think that what can be game changing about clinical decision support. And I think that's just where it hasn't gone yet. So the idea that, today clinical decision support surfaces an insight to a clinician, the clinician reviews and does something about it. The next world, where we're not quite there yet, and where we would certainly need more view is, I think, if AI is going to act on it, what is it doing, and what is it surfacing? So with the error and bias, and again, I would say it's like the places where we see CDS the most, again, I mentioned sepsis. There's really, I would say probably a handful where it's being used today, and there's lots of different ways to do it. I imagine this topic around error and bias um, might grow as we enter the more clinical world. Um, and it's one of those, it's a very complicated sort of ROI equation too, as to how you think about what this means. Many times for organizations, reducing error and bias really has everything to do with just not being in the news. Um, at the end of the day, I think if they feel protected around that, and I would maybe even argue and say that a lot of the AI algorithms that exist today, no one really has like perfect clarity as to whether they're biased or whether they're not. And there's so many sepsis algorithms out there, for example. And so I think it's just a lot harder to understand at the end of the day. And versus something like ROI, which gets very quickly to how do I even justify paying for this? So I expect it to change. I would say it's probably the minimum bar of like, is this really going to get us into trouble, or do we have just sort of a backstop to make sure that if it goes wrong, there's someone dealing with it, um, versus something like ROI, which really gets to the heart of like, can we even do this?
Yeah. I also imagine whether this is also a function of, like, at least for the most used use cases in Gen AI space, like clinical documentation and administrative, there's always right now at least a human review in the loop. And that's why, because I don't think that the issue is that there are no errors and biases, and we have no issues with hallucination and things like that. And also, like, for Gen AI use cases right now, there's no standardized agreed upon methods for evaluations either, which exists for CDS use cases. I mean, I was very it piqued my ears to see errors and bias at the bottom of the concerns, but hopefully it changes as the understanding improves around Gen AI use cases. Yeah.
Yeah. Um, I also think there's like the leaders and the tailored followers when it comes to solutions. So, I think about like even with scribing, yes, a clinician reviews it, so you feel like you have a bit of a backstop there. But some organizations really did take the time and effort to go, especially the big ones that have resources, really go into like where's the error and bias, yeah, where's hallucinate, because sometimes I mean obviously you're influencing clinician perspective, but I do think that not every organization has that capability. So if you see a Kaiser using this, you're like, what? And they validated it, and the a bridge has put this on their website that it's been validated. Like you feel certain certainty and comfort in that, even if you don't have the full capabilities to do the full analysis of whether this is fit for your population and how accurate and inaccurate it is when it writes up the summaries, things like that, that there's, that whole process of evaluation um, becomes less of a barrier as companies become more mature in the space.
We have a couple more minutes left. If anybody else has any comments or questions for Han. Sure, some time.
I'm curious, I didn't get a chance to ask everyone just where they were, but I'd love to just hear a little bit from the audience as to what you've seen, what resonates or doesn't resonate with you in terms of some of the findings that we had. Any brave souls want to share?
Yeah,
I
feel
can
free.
jump in if you can hear me. My name's Chris, and I run a consulting firm working with small to medium-sized healthcare providers, mostly group practices and mental health. And definitely consistent on Scribe, clinical note-taking being the first and easiest win. I think the challenge that I've heard from multiple providers is, how do I actually use this to multiply my time, right? So I can, because the only method they have for increasing revenue is see more patients, but there's only so many patient hours. And so it sort of seems like a nice to have, and certainly it's a big support in note writing, but it's some of the bigger picture transformation that people talk about just doesn't trickle down to that type of use case.
Very interesting.
Yeah, it's interesting. Anybody else have any comments? Thank you so much, Hong, for a very interesting presentation. And we'll watch out for the follow-up survey and hopefully, bring you back to share results from that as well. Yeah.
Yep, we'll go on that.
Thank you.
Thank you
Thank you
so
so
much for
much.
having me.
Of
See you.
course.